Hello, it's Dmitry again. Today we'll be covering, make sure I'm saying this correctly, the first aid clinical algorithms for the USMLE Step 2 CK. Now we're covering the cardiology section. So this will be the first video for the cardiology section. I don't know how long this will be. It is about 51 pages, if not mistaken. Now, most of the time it takes me about an hour to cover 10 pages for most textbooks. However, this is mainly diagrams, and so it might be a little bit of a different pace on a page per, hour basis. But let's see. And let us begin. 1.1, chest pain. And this is all in the internal medicine section overall, which is more than just cardiology. So chest pain. Let's say, for example, it's non-cardiac. Well, first of all, see page 9 to 11, but also, is that page or paragraph? I think it might be paragraph, or pages 9 to 11, okay. Pages 9 to 11, okay. Pulmonary causes, GI causes, musculoskeletal causes, and other causes miscellaneous. What about chest pain that is cardiac in nature? Well, it could be ischemic or non-ischemic. If it's non-ischemic, we should think about things like pericarditis, myocarditis, decompensated heart failure, Prinzmetal angina, valvular heart disease, and aortic syndromes. What about if it's cardiac but it's ischemic issues? Let's say it's ACS or stable/chronic angina. So acute coronary syndrome or stable/chronic angina. In that case, we have to go to look at the pages 3 through 5. And for reference, we're on page 2 right now. We have this little text right here. Let's read about it. Chest pain is one of the most common reasons in which a patient presents for medical care. There are many etiologies of chest pain or discomfort, and certain life-threatening pathologies cannot be missed. Acute chest pain or discomfort can be framed into 3 primary categories: myocardial ischemia, non-ischemic cardiac chest pain, and non-cardiac chest pain, as we saw with the diagram over here. That's basically the 3 categories that they go into. Myocardial ischemia usually presents with a typical chest pain, which often consists of chest, arm, and or jaw pain described as a dull, heavy, tight, or crushing. It may be accompanied by shortness of breath, nausea, vomiting, abdominal pain, diaphoresis, as well as a sense of anxiety or uneasiness, and can be triggered or exacerbated by physical exertion and stress. If ongoing myocardial ischemia is suspected, the patient should be evaluated with basic diagnostic tools like EKG and cardiac biomarkers. For the acute coronary syndrome, a spectrum of clinical presentations caused by plaque disruption or coronary vasospasm leading to the inadequate oxygen delivery to meet the heart's metabolic demands. If myocardial ischemia is a severe or prolonged in duration, irreversible ischemic injury occurs, leading to myocardial infarction. Both non-ischemic cardiac chest pain and non-cardiac chest pain usually presents with atypical chest pain, which is frequently described as epigastric or back pain or pain that is sharp, stabbing, or burning, or suggestive of indigestion. If the chest pain has these non-ischemic qualities, there is a 95% negative predictive value. Non-ischemic causes of cardiac chest pain include acute inflammatory or infectious processes, that is to say, infective endocarditis, pericardial disease, aortic dissection, valvular pathologies, and heart failure. The majority of patients that present with chest pain will have a non-cardiac etiology. The most common etiologies of chest pain are pulmonary, that is to say, pulmonary embolism, pneumothorax, GI, that is to say, GERD or dyspepsia, and MSK, that is to say, for example, costochondritis. We will discuss these etiologies in more depth in the following pages. In addition, some patients that present with acute chest discomfort may have underlying psychiatric conditions like panic disorder and experience chest tightness associated with difficulty breathing, anxiety, and heart palpitations. When a patient presents with chest pain, the first step in management is obtaining vital signs, including pulse oximetry and a thorough cardiomyopathy examination. If the patient is hemodynamically unstable, follow the ACLS protocol. If hemodynamically stable, obtain a thorough history on the quality, location, including radiation, and pattern, including onset, duration, and provoking or alleviating factors of the pain. Obtaining a description associated with symptoms, that is to say dyspepsia, palpitations, hemoptysis, and the patient's prior medical history, for example, coronary artery disease, connective tissue disease, malignancy, is also helpful. Pulmonary etiologies, for example, pulmonary embolism, are usually associated with the dyspnea and or an elevation in oxygen requirement, and the chest pain is also often pleuritic in nature. Acute aortic dissection often presents with terrible tearing chest pain. MSK pain, musculoskeletal pain, is often reproduced with certain movements or upon palpitation of a specific area. A burning quality or exacerbation with eating can be suggestive of a GI etiology. Altogether, the patient's demographics and the chest pain characteristics, as well as the basic diagnostic tools like EKG, chest x-ray, and cardiac biomarkers, narrow the differential and help guide the management. And so before we continue, I just want to make sure that this text, it looks very small. I mean, it's small for me to read in my own page. I'm sure it looks probably a little bit more difficult for you to read it. So I'll go in a little bit. I don't want to have the, I don't exactly want the the antlers to get in the way of things, or my head. A little icon, a little presentation of myself, a window into my soul, you could say. I don't want that to get in the way of the text, nor do I want the text to be so small you can't read it for that reason either. So that looks reasonable. If I go a little bit further with it, would it be reasonable? Is that too far? Yeah, I mean, it is a little bit, yeah. Can I move it like this? Yes, I can. It seems a little bit silly to you now. I'm just spitballing, right? I'm just trying to figure out where I can go with this stuff. Is that better? Would you say that's a better situation? There's a little bit of overlap right there. Maybe you have to get these shaved down, these antlers or something like that. I don't know. But we'll continue. Yeah, this is easier to read, I think. So we're on page 3. Wow, we made a lot of progress so far. Anyway, so 1-2, ischemic chest pain. Chest pain, pressure like substernal and or with exertion. So if we have that kind of chest pain, pressure like substernal or with exertion, there's a little note right here. It says ischemic characteristics. A, with exertion, improves with rest or nitroglycerin. Left-sided substernal radiates the jaw or shoulder. Squeezing, pressure like, associated with nausea, dyspnea, fatigue, lightheadedness. And then 2, because it says 1 and 2 here for chest pain. 2, the other kind is called is pain characteristics with help rule out ischemia. So let's say that we were talking about before with ischemic characteristics. What about things that rule out ischemia? Changes of respiration, changes of position of body, reproducible to touch. D, sharp, knife-like, or focal. Those imply non-ischemic causes. So let's say we do so we have that chest pain. Okay, maybe it's ischemic, maybe it's not ischemic. We're saying here pressure-like, substernal, and/or with exertion. Let's do an EKG. Okay, we do an EKG, and let's say, for example, based on the EKG, we're seeing, ST segment elevation in two contiguous leads. So we're saying ST elevation. So that's a STEMI, right? So ST segment elevation, myocardial infarction, STEMI. What do we do in that case? We go for a load with ASA, aspirin, plus P2Y12 inhibitor, DAPT, DAPT, heparin, revascularization within 90 minutes, PCI versus thrombolysis. So these are just footnotes, basically. I mean, for aspirin, aspirin is aspirin. DAPT, dual antiplatelet therapy. PCI, percutaneous coronary intervention. And then we say, it goes here, so let's say, for example, we took these drugs, we took aspirin, a P2Y12 inhibitor, heparin, so forth. We did revascularization within 90 minutes. We can talk about the post-MI complications on pages 6 and 7. Let's say we do the EKG. We say, actually, it's not ST elevated, it's ST depressed or non-specific T-wave abnormalities. Well, in that case, we have to do cardiac biomarkers, so troponin and CKMB, right? And so let's say it's positive for troponins. Let's say it's positive for these cardiac biomarkers, right? What does that mean? Now we have an NSTEMI, non-ST segment elevated myocardial infarction, or NSTEMI. In this case, we're going to do a heparin drip or low molecular weight heparin, a DAPT load, a risk stratification to determine the time to revascularization. And again, complications, you can look at post-traumatic complications on a different page. What about, we're talking about, okay, we have ST depression, sure, but let's say we were negative for biomarkers. We didn't have biomarkers positive. What's going on in that case? Well, we have symptoms resolved with rest. Okay. Well, if they resolve with rest, let's say they don't resolve with rest, but let's say they continue. The biomarkers are not elevated, but they do not resolve with rest, the symptoms. We have unstable angina. Unstable angina is when you have ST segment depression, biomarkers are negative, but it does not resolve with rest. Rest is not the issue. It's called unstable angina. What do we do in that case? Well, we do a stress test, and the stress test would be, if it's positive for reversible ischemia, then we can go for coronary angiography plus or minus angioplasty or bypass surgery. And for that, it says here for bypass surgery, if revascularization is indicated, send patient for coronary angiography plus or minus angioplasty or bypass surgery. Coronary artery bypass surgery shows lower mortality in 3-vessel disease, greater than 70% stenosis, left main occlusion, 2-vessel disease, diabetes, or persistent symptoms despite maximal medical therapy. Okay, let's go back to here. Symptoms with resolve with rest. Let's say it does resolve with rest. Okay, resolves with rest. Then we have we'll check for cardiovascular risk factors and evidence of coronary artery disease / plaque. Let's say it's positive. Let's say we have positive for the risk factors and evidence of the CAD and plaque. If it's positive, then we have stable angina, right? Okay, so yeah, we have symptoms, but it improves with rest. What do we have? We have stable angina. In that case, what do we do? Aspirin again, a beta blocker, ranolazine, and nitrates, okay? What about, let's say, for example, okay, sure, it's ST depressed. Okay, sure, it improves with rest. Let's say, for example, we don't actually have these sorts of really notable cardiovascular risk factors. We don't have evidence of CAD. Well, in that case, what we have is called Prinz metal angina or vasospasm. So what do we do if we have Prinz metal angina? We have this sort of angina that's going on. It's not necessarily because we have CAD. It doesn't necessarily we have coronary artery disease. We have it for some other reason. Well, in that case, what do we do about Prinz metal angina? Calcium channel blockers, beta blockers, and nitrates. So sort of a similar overlapping kind of condition. It's not stable angina and Prinz metal angina. Both of these cases, they will have beta blockers. They'll do nitrates, but the difference is that for stable angina, they'll be ranolazine and aspirin, but for Prinz metal angina, they go for calcium channel blockers. Not too bad so far. So 1-2, page 4, ischemic chest pain, ST segment elevation, myocardial infarction, STEMI. This is a little vignette for you guys. Take notes. Be a critical thinker in this matter. So ST segment elevation and myocardial infarction, STEMI, which was for reference. Let's go back to the page here. STEMI, EKG. You have ST segment elevation in 2 contiguous leads. Therefore, you have STEMI. Therefore, you go for aspirin, P2Y12 inhibitor, DAPT, heparin, revascularization within 90 minutes. Okay, so let's talk about it. STEMI. A 55-year-old male with, was it PMH, pulmonary mitral, I don't even know, sorry. It is a progressive macular, no, that can't be it. It's great, it's more than one thing. It could be paroxysmal nocturnal hemoglobinuria, which is what it probably is. Less likely, progressive macular hypomelanosis. I suspect it's not that. But let's say, for example, it's paroxysmal nocturnal. No, nocturnal is an N. Sorry, I am lost. A 55-year-old male with PMH of diabetes and hypertension presents with crushing substernal chest pain, improving with rest and sublingual nitroglycerin. The pain radiates to his neck and arms and is associated with shortness of breath, nausea, vomiting, diaphoresis, and lightheadedness. For reference, diaphoresis is sweating. I like to say, I don't like saying the word dyspnea. I like saying, shortness of breath, but for some reason, diaphoresis doesn't faze me. I guess I don't like making the word dyspnea. I don't like the sort of the combination of consonants, I suppose. Doesn't roll off the tongue in the way that diaphoresis does. Anyway, exam. Blood pressure is 86/50. Heart rate is 120. The oxygen is 88% on room air. He has bilateral crackles and elevated JVP, jugular venous pressure, and is cold and clammy. Labs/imaging, EKG shows ST segment elevation into contiguous leads. That should give you a hint that it is STEMI. That is what we talk about when we're talking about what STEMI is. So for management, what do we do? 1. Revascularization is key. Emergent angiography and PCI should be performed. If possible, if PCI cannot be performed within 90 minutes, perform thrombolysis, TPA, tissue plasminogen activator, retiplase, streptokinase. If there is no contraindications, while awaiting revascularization, load with a DAPT and start heparin drip. Now, for reference, remember DAPT is going to be dual antiplatelet therapy. For reference, I also want to go check PCI. I mean, you could say, you should know what that is. I mean, I should know what that is. I should know all the medical abbreviations off the top of my head. Percutaneous coronary intervention. Okay. So if percutaneous coronary intervention cannot be performed within 90 minutes, perform a thrombolysis. Okay. 2. So that's 1, revascularization is key. 2. If cardiogenic shock is present, consider mechanical support devices. 3. Give the patient oxygen support, pain medications, and nitrates, nitroglycerin for example, as needed/tolerated. 4. During hospital course, start statin, beta blockers, and an ACE/ARB. They mean ACE inhibitors/ARB. Optimize other cardiovascular risk factors like hypertension, hyperlipidemia, smoking, and diabetes. Complications: cardiogenic shock, heart failure, bradyarrhythmias, ventricular arrhythmias, see pages 6 and 7, post-MI complications. High-yield facts. Treatment for MI, do not let the patient bemoaning in pain or bemoaning in pain. Beta blockers, B, morphine, M, O, okay, so B, beta blockers, M, morphine, O, oxygen, A, aspirin, plus A, additional antiplatelet agent like clopidogrel, prasugrel, or ticagrelor, and nitrates. I'm going to be honest with you. This is a criticism I have for the Step 1 first aid textbook. I just don't like a lot of the acronyms they come up with. It's like they feel like they need to put an acronym anywhere it's theoretically humanly possible, and it doesn't necessarily serve a very good purpose because now you have like a laundry list of different acronyms for things that you don't really, it's not really useful for, if you understand what I'm saying. Let us continue then. An inferior wall myocardial infarction, MI, that is to say, for example, so a right ventricular infarction, avoid nitrates due to risk for hypotension, preload dependent. Contraindications for thrombolytics, major GI or brain bleed, recent surgery last 2 weeks, severe hypertension greater than 180/110, non-hemorrhagic stroke in the last 6 months. Aspirin plus beta blockers, medications that decrease mortality, commonly occluded coronary arteries, LAD greater than RCA greater than circumflex. So LAD is the worst, most likely, most common, followed by right coronary artery, followed by the circumflex. Ischemia, so left anterior descending is the most common, for reference. Ischemia can come from different pathophysiologic processes, plaque rupture type 1 MI, demand ischemia type 2 MI, coronary artery dissection. Coronary angiography is the gold standard for diagnosing acute coronary syndrome. Women, the elderly, diabetics, and post-heart transplant patients may have clinically silent or atypical presentations of MIs. SCAD, spontaneous coronary artery dissection, young women, other collagen/mixed connective tissue diseases. EKG localization of STEMI. Location, vessel, EKG leads of ST elevations or Q waves. Location, so anterior septal, the vessel would be, so let's say we have so these are STEMIs, ST elevated MI. So let's say it's anterior septal location. What vessel would it be? The left anterior descending, LAD, or LAD. Let's just call it LAD for the sake of this. EKG readings would show what? V1 and V2 elevations. Or ST elevations or Q waves. Okay, so what about anteroapical? Again, another LAD issue. You would see V3 and V4 problems. What about anterolateral? That's an LAD or left circumflex issue. Where would you see this at? V5 or V6. ST elevations or Q waves there. What about lateral? Lateral, you see this at the left circumflex, and it would be either with lead 1, or so you could say lead I, or I, because it's a single Roman numeral. Or yeah, you can say 1. 1 is fine, because it's called V1 in other case, so 1 or AVL. Inferior, which is going to be right coronary artery, is 2, 3, and AVF. Posterior would be PDA, is you have V7 and V9, ST depression in V1 through V3. An easy way to remember, I think, is my understanding, is that LAD is going to be V1. So V1 through V6 issues are probably going to be LAD, probably. Left circumflex is probably going to be V5, V6, I, and AVL. And then inferior is going to be, 2, 3 AVF or RCA. So if you have a 2, 3 or AVF, think RCA, think inferior location. When you have an AVL or I issue, think lateral or left circumflex. When you have a V1 through V6 issue, it's probably LAD. And therefore antero something. Septal, apical, lateral, something like that. Non-ST segment elevation, myocardial infarction, NSTEMI. Okay, let's go back. Let's go to another vignette. A 55-year-old male with a PMH of past medical history. Now I got it. Sorry, past medical history of diabetes and hypertension presents with crushing substernal chest pain, improving with rest and sublingual nitroglycerin. The pain radiates to his neck and arm and is associated with dyspnea, nausea, vomiting, diaphoresis, and lightheadedness. Exam: blood pressure is 160/80, heart rate is 98, oxygen is 94%, and room air. Lab/imaging, EKG shows ST depressions in V2 through V4 that were not previously present. Troponin is elevated. And remember, V2 through V4 means, I believe he said LAD with that one, as an anteroapical. Was that V2 through V4? Was that, yeah, V2 through V4, so that's hiding between anteroseptal and anteroapical. So that's going to be LAD regardless, though. Management for this ST depressed situation, this NSTEMI. Load with a dual antiplatelet, was that dual, what was this? Dual antiplatelet therapy, so AP just antiplatelet, okay. Where were we? So management for the NSTEMI. Load with a dual antiplatelet therapy and start heparin drip. Risk stratification for when to revascularize. If persistent pain, hemodynamic instability, or electrical instability, take to cath lab for coronary angiography plus angioplasty. Give patient oxygen support, pain, medications, and nitrates, that is to say nitroglycerin, as needed/tolerated. During hospital course, start a statin, beta blocker, and ACE inhibitor/ARB. Optimize other cardiovascular risk factors, hypertension, hyperlipidemia, smoking, diabetes. Complications would be referred to STEMI. Okay. So similar complications. What were those complications? Cardiogenic shock, heart failure, bradyarrhythmias, ventricular arrhythmias. High yield facts about the NSTEMI. Refer to STEMI. Okay, great. EKG, just go back if you need to, okay? EKG differentiates STEMI from NSTEMI. With the STEMI, EKG shows ST segment elevations, hence the name ST elevated myocardial infarction, right? With NSTEMI, EKG does not show ST elevations, hence the name non-ST elevated, right? But can show ST changes, that is to say ST depression, T-wave inversions, non-specific changes. Both NSTEMI and STEMI are associated with elevated cardiac enzymes indicating myocardial necrosis. So when you have those biomarkers, like the troponins and stuff like that, that's an indication of the necrosis, of an actual MI going on, or of having happened. What about unstable angina? A 55-year-old male with a past medical history of diabetes and hypertension presents with crushing substernal pain, improving with rest, and sublingual nitroglycerin. Exam blood pressure to be 160/80, heart rate is 98, oxygen is 94% of room air. Labs and imaging, EKG shows ST depressions in V2 through V4 that were not previously present. Serial troponins are negative though. And that's why it's not actually an MI. It's, in this case, unstable angina. Well, how do you treat unstable angina? Load with a dual antiplatelet therapy and start heparin drip. Risk stratification for revascularization versus stress testing. If persistent pain, hemodynamically unstable, or electrical instability, take to cath lab for coronary angiography plus or minus angioplasty. During the hospital course, start a statin and beta blocker. Optimize other cardiovascular risk factors: hypertension, hyperlipidemia, smoking, diabetes. Complications: progression to myocardial infarction. High yield facts for the unstable angina. Medications that decrease mortality would be aspirin and beta blocker. Hormone replacement therapy is not protective in postmenopausal women. Stress testing, functional assessment with exercises stress testing is preferred over pharmacological stress testing if the patient is able to exercise. Resting EKG abnormalities that preclude a stress EKG, left bundle branch block LBB, pacemaker ondigoxin, left ventricular hypertrophy with strain pattern. Pharmacological stress testing involves dipyrimidine/adenosine or dobutamine. Dipyrimidine/adenosine can worsen the bronchospasm. Avoid in severe or active asthma. Before any stress test, avoid caffeine and beta blockers. Okay. What about stable angina? Stable angina, a 55-year-old's been through a lot. A 55-year-old male with a past medical history of diabetes and hypertension presents with recurrent episodes of chest pain for the past 6 months that worsen with exertion and resolve with nitroglycerin or rest. The exam, blood pressure should be 160/80, heart rate should be 98, oxygen at 94% of room air. Labs and imaging, EKG does not show any new or concerning changes. Serial troponins are negative. Again, so EKG is basically normal-ish, right? Unlike the unstable angina. And the serial troponins are negative, like unstable angina, because this is an angina, this is not an MI. Well, how do we manage this stable angina here? What do we do? Well, management would be beta blockers and aspirin. Other anti-anginals would be nitrates, nitroglycerin, isosorbide dinitrate, mononitrate, ranolazine. Stress testing to risk stratify coronary artery disease. Optimize other cardiovascular risk factors: hypertension, hyperlipidemia, smoking, and diabetes. What is that associated for? Which one is that? ST segment elevation, myocardial infarction. EKG shows the inferior ST segment elevation, myocardial infarction, ST segment elevation in lead V1, consistent with right ventricular infarction. So lead 1, therefore right ventricular infarction. Does this say V1 or 1? V1. So V1 would be like an LID issue, right? If it's V1, it's an anterior septal or left anterior descending artery issue. Okay. So what about going back into stable angina? What are the complications of stable angina? With time, plaques can worsen and patients can develop acute coronary syndrome / myocardial infarction. So it just can basically progress. High yield facts about stable angina refer to unstable angina for the high yield facts, which we talked about before. They love saying that. High yield facts refer to what we talked about before. Patient history distinguishes stable from unstable angina. Stable angina presents with substernal chest pain that is precipitated by exertion and relieved with rest or nitrates. In contrast, unstable angina presents with chest pain that is 1, new onset, 2, progressive, triggered with less exertion, lasts longer, less responsive to medications, and 3, occurs at rest. Both stable and unstable angina do not have elevated cardiac enzymes, though, which would be characteristic of an MI. What about Prinzmetal angina or coronary vasospasm? A 35-year-old female with a past medical history of hypertension and tobacco use disorder presents with recurrent episodes of chest pain, usually at rest, which lasts last less than 10 minutes and resolve with nitroglycerin. She is not currently experiencing chest pain. Exam, blood pressure is 120 over 80. Heart rate would be 98, oxygen 94%, room air. Labs and imaging show EKG without any new or concerning changes. Serial troponins are negative. Management, again, this is important. Troponins are negative. The EKG is nothing concerning about it. It's just that they have this, that they have hypertension, tobacco use, and chest pain at rest, which only lasts about 10 minutes, so it resolves in nitroglycerin. So how do you treat transmetal angina? Nitrates, calcium channel blockers, counsel on smoking cessation if applicable, and then 3, stress testing to risk stratify coronary artery disease. Complications of transmetal angina would be this condition is difficult to treat, and many patients have recurring symptoms. Episodes of coronary vasospasm are associated with development of arrhythmias, ventricular fibrillation, VFib, and sudden cardiac death, which is not fun. High yield transmetal angina facts. And this is not just called, it's called transmetal, but it's also called coronary vasospasm, which kind of gives you a little bit more information about what's going on, perhaps. Some high yield facts about that, though. Classically affects young women at rest instead of with activity in the early morning and is associated with transient ST segment elevation. Tobacco smoking is a risk factor. Common triggers would be illicit drugs, especially cocaine, alcohol, and triptans. Avoid beta blockers because they can increase the vasospasm. So where are we now? We're 31 minutes in. That's actually pretty good because I've not taken any breaks yet. So I will take a break now. If I were you and I were listening to this recording, which is what you probably are doing right now, my recommendation is just to simply skip ahead. So do that now, and I'll be back, presumably. Okay, I am back. Yeah, so I mean, I was looking at my older videos just as a detour from what we're doing right now. There's a little bit of a digression, and I'm like, I was able to pull through an hour straight, and I'm like, what am I doing now? I'm doing like 15. I'm doing like breaks after 15 minutes or something. What's going on? So I need to get back into it, you know. But yeah, let's see. You know, I'm also thinking about like maybe you should have like almost like intro music or something during breaks. Have you ever seen that? You've seen like a movie back in the day where they have like an interim thing, so you can get up out of the movie theater and like you know, go to the bathroom and that kind of thing. Maybe I'm thinking like, should I do that? I don't know. They could just skip ahead if they wanted to, and they can always pause if they want to, unlike a movie theater. So I don't know. Maybe have a little bit of music, a little waiting, a little bit of a time card or something. I'm not sure, but anyways, let's continue. So we have a new graph right here. We're on page 6. Okay. We're on page 6. Recent myocardial infarction, now with changes in clinical status. Okay. We have some testing here. It says EKG, troponins, /CKNB, right? The biomarkers, and physical exam. So let's say, for example, we do that, and we have sinus bradycardia. Well, in that case, if we have sinus bradycardia, that means we're going to go for symptomatic lightheadedness, syncope, palpitations, right? So if we have those symptoms, we have symptomatic lightheadedness, syncope, and palpitations, then we either going to be, if it's negative, if we're negative for that, just closely monitor it, okay? So if sinus bradycardia, but it's negative for the symptomatic issues of lightheadedness, syncope, palpitations, if it's negative, closely monitor. If it's positive, then we probably need to go temporary pacemaker and atropine. Okay. What about we do the EKG, biomarkers, and physical exam, and we say, okay, Canon A waves, right-sided MI, 0 to 1 days. What do we think? Third degree AV block, right? Third degree AV block if we have this Canon A waves, right? What do we do in that case? Same stuff. We're talking about if it's positive for the symptoms. We do temporary pacemaker and atropine. What about if we have fever, pleuritic chest pain, global ST segment elevation, and T-wave inversion, pericardial effusion, okay, 1 to 6 weeks. We're thinking what? Dressler syndrome, right? And what do we do for that? NSAIDs, glucocorticoids, and colchicine. What if we have jugular venous descent, jugular venous pressure elevation, okay, distant heart sounds, pulsus paradoxus, hypotension, 3 to 5 days after transmural infarct? What do we think? Tamponade, right? Cardiac tamponade, and free wall rupture. What do we do in that case? Pericardiocentesis, pericardial window. Yeah, that's a serious issue. If you have cardiac tamponade, that can really kill you, you know. So just be aware of that. What if we have a loss of pulse, disorganized rhythm, wide complex tachycardia, 0 to 1 days? What do we think? VFib, ventricular fibrillation, or ventricular tachycardia. In that case, we should be thinking about ACLS. So ACLS, I just want to confirm what that is because I am not confident in any answer whatsoever. Advanced cardiovascular life support. I would have not guessed that. I'd have to phone in the friend, you know, that kind of thing. So, advanced cardiac life support, is that right? It seems to be. In that case, go see ACLS algorithm, page 27. Let's say we have a new murmur, okay, Rales / pulmonary edema, 3 to 5 days after transmural infarct. What do we think? Well, what we want to do is do an echocardiogram. In that case, we can confirm papillary muscle rupture. In that case, what do we want to do is do a cardiothoracic surgery, consult for surgical repair. What about we found significant anterior infarct or severely decreased ejection fraction, weeks to years? What do we think? Well, we need to do another echocardiogram in that case, and we're going to find probably an aneurysm / mural thrombus. Aneurysm with mural thrombus. What do we do to treat that? Anticoagulation. More information on page 113, which we'll be not looking at certainly in this video, at the anticoagulation table. So now we're going to go on to all the details for that stuff here. You know, there's a natural rhythm to it, I think, to this so far. There's a diagram, and then they have a little bit of explanation at the end with vignettes. And so we'll probably cover at least this section again, and then we'll probably wrap up for this area, I would assume. Post-MI complications, Dressler syndrome. Or maybe you'll go further, who knows? Well, if you're watching a recording, you would know. Dressler syndrome. A 55-year-old male with a past medical history of recent... Also, fun fact for you, they went over from... They went 55M versus doing a 55-year-old M. 55M, just like that, one word. 55M... 55-year-old... You should give a name. It's a little bit dehumanizing. 55-year-old male? Like, isn't there a name? Isn't there a story? Doesn't he have a past, a future? What's going on? Anyway. A 55-year-old male with past medical history of recent MI, SP, PCI... SP, sorry. This is a learning experience for me and you, I suppose. Medical abbreviation. Status post. Status post? So, SP, status post. Oh, status post, like, okay, the Latin status post. Okay. So, like, his status is post whatever, right? So he's post PCI, which is we said that was percutaneous coronary intervention, something like that. 4 weeks ago, presents with pleuritic chest pain, fever, palpitations. This is another digression. But why on earth do they think I know what SP means, but I don't know what beta blocker is? They put a BB, little annotation, beta blocker. I know what those are, okay? But why not do that for something like PC, like the not PCI, the SP? That seems like a little more relevant. I don't know if they gave an explanation for PCI or not. I think I might have looked it up. I looked it up, I believe. But anyway, let's go back before we had those digressions. So Dressler syndrome, a 55-year-old male with a past medical history of recent myocardial infarction, status post PCI, percutaneous cardiac intervention, 4 weeks ago, presents with pleuritic chest pain, fever, palpitation, shortness of breath, and malaise. Exam, fever of 102.2, presumably Fahrenheit, I'd imagine. Tachycardic with a pericardial friction, Rob. Heard on auscultation. Lab/imaging, elevated white blood cells with left shift, elevation in ESR and CRP, and higher titer of anti-heart antibodies. EKG shows global ST segment elevations and T-wave inversions. TTE shows a small pocket of pericardial infusion. And I think TTE is transthoracic echocardiogram, if I'm not mistaken. Management, aspirin plus colchicine for Dressler syndrome. Avoid glucocorticoids and NSAIDs if within 4 weeks of MI, as they may impair the healing process and cause ventricular rupture. In severe cases, that is to say, for example, significant pericardial effusion, symptoms indicate imminent cardiac tamponade or constrictive pericarditis. Well, in that case, do pericardiocentesis with subsequent catheter drainage, generally 24 to 48 hours, and concomitant initiation of anti-inflammatory treatment. Symptomatic bradycardia or AV blocks. A 68-year-old male with a past medical history of hypertension and diabetes presents with sudden onset of retrosternal chest pain. The exam, bradycardic, nausea, active emesis, vomiting, diaphoretic. Labs and imaging show EKG with second-degree Mobitz type 2 AV block, ST segment elevations in 2, 3, and AVF. Management, temporary pacemaker. If persistent after appropriate revascularization, permanent pacemaker. See pages 30 through 31, bradyarrhythmias. What about papillary muscle rupture, flail leaflet/VSD? A 68-year-old male with a past medical history of hypertension and diabetes admitted 2 days ago for acute ST-elevated myocardial infarction, STEMI, now reports acute onset shortness of breath. Exam, abrupt pulmonary edema, hypotension, loud holosystolic murmur. Lab/imaging, Transthoracic echocardiogram shows a new anatomic defect, acute, severe mitral regurgitation, or new ventricular septal defect. So like a VSD or a mitral regurg. Management for this condition, again, this is papillary muscle rupture, flail, leaflet, /VSD. Cardiac surgery, consult STAT. Let's just make sure I know what that is, because I do not. Or maybe I do, I don't know the acronym at least. What condition is this we're talking about? Papillary muscle rupture? Papillary muscle rupture. So STAT, please tell me what that means. STAT, medical abbreviation. So STAT, come on. Oh, no. Is that... Do they mean STAT as in they're not, it's not an acronym, they're actually using... Okay, so why do they do that to me? I'm sorry, but everything else is an acronym. STEMI, TTE, PMH, M. You know, it's like, what are we doing here? And then it's like, oh no, STAT just means they're just emphasizing that it's important. Is that really? Is that true? If that's the case, why do they put a period at the end of it? Why not just make that an exclamation point? Man. I'm crashing out right now over a medical textbook. Anyway, cardiac surgery consult, STAT. Manage cardiogenic shock. See pages 15 through 26, cardiomyopathy/cardiogenic shock. What about tamponade/free wall rupture? A 68-year-old male with a past medical history of hypertension and diabetes admitted 2 days ago for acute anterior STEMI is found to be unresponsive by his nurse. Exam, pulseless electrical activity, lab/imaging, emergent point-of-care ultrasound while running ACLS protocol. Again, that's going to be advanced cardiac life support, I believe. Protocol shows new left ventricular free wall rupture and severe pericardial effusion with right ventricular diastolic collapse. Management, follow the ACLS protocol. Pericardiocentesis and cardiac surgery, consult STAT. I'm sorry, is that really an acronym? Not an acronym. They say STAT with capital STAT twice. It seems like it just seems like it's the word stata meaning immediately. At once. So, I don't know. Maybe I'm wrong. Maybe I'm right. Who knows? Ventricular fibrillation, VFib. Ventricular tachycardia, VTAC. A 68-year-old male with a past medical history of hypertension and diabetes admitted 2 hours ago for acute STEMI, now status post PCI. See, status post, no, SP. Now you say status post. You said SP abbreviated first, and then you gave status post later on, which is not the way you should do that. Anyway, PCI is found to be having a new rhythm on telemetry. Exam, tachycardic diaphoretic hypotensive. Labs/imaging, telemetry, and 12-lead EKG shows sustained monomorphic ventricular tachycardia. Again, they don't explain what VT means. I know what it is because of the context, but still. Which quickly degenerates into ventricular fibrillation. Management for the VFib. Follow the ACLS protocol. Look for persistent underlying ischemia and electrolyte derangements. Usually take the patient back to the cath lab given risk of reocclusion or of coronary artery. 3. Implantable cardiovascular defibrillator, ICD. Indicated for the left ventricular ejection fraction of less than 35% at least 40 days after unrevascularized MI or 90 days after the PCI/CABG. Again, they don't tell you what any of those words mean. So yes, implantable cardioverter/defibrillator. So that ICD, they tell you that one. Left ventricular ejection fraction, LVEF. I know that one. Myocardial infarction, MI, sure. PCI, percutaneous coronary intervention, and then CABG is the coronary artery bypass graft. Is that right? Coronary artery bypass graft, CABG. Yes. Again, they don't tell you that. They just say, oh, yeah, the PCI/cabbage. You know what I'm talking about? Like, well, maybe I do. Maybe you do. Aneurysm/mural thrombus. A 68-year-old male with a past medical history of hypertension and diabetes, admitted 3 days ago for acute anterior STEMI, now status post PCI, is currently feeling well. The exam blood pressure is 110/80, heart rate is 70, the oxygen is 98% on room air, no other findings. Labs and imaging give a transthoracic echocardiogram with a left ventricular ejection fraction severely decreased to 10%. Wow. Ventricular aneurysm cavity, and mural thrombus. Okay, that's pretty serious. Mural thrombus. Okay, what do we think? Management, treat heart failure, diuretics, GDMT, and start anticoagulation. So again, GDMT. I feel like I need it's been very useful. Guideline directed medical therapy. Okay, guideline directed medical therapy. Okay, so and start anticoagulation. Science Bradycardia, see page 30. Again, we're talking about a mural thrombus and an aneurysm, such aneurysm. And that goes us into our next section here, all about non-ischemic chest pain, cardiac. So we were talking about the ischemic stuff just a moment ago, if I'm not mistaken, right? Yeah, ischemic stuff right here. Posted in my complications, I should say. And this is a more broad. Well, no, this is ischemic. We did ischemic, the complications of MI, and now we're going into the non-ischemic stuff right now. In theory. And now, one of the things I want to say is, what time is it? We're approaching the hour. We're in 52 minutes. So I'm basically going to probably take a break at each individual section. And that'll probably be, each section might be 25, 22, probably less than 30 minutes, but probably more than 15. And then I'll come back to you. So again, just skip ahead if you're going to be watching the recording. Okay, I am back, and I think this will be my final section for this video. We're on page 8 right now. This is a little bit longer than I was expecting, because actually, I was saying before, I usually do 10 pages per thing, 10 pages per hour, but this thing has a lot more diagrams in it, so maybe it's not as bad. Well, so far, it's probably been a little bit worse. It's been a little bit more heavy-handed, so I'm a little bit surprised, I guess you could say. Especially considering the page 1 is basically nothing. It's like a title page. So, hopefully this is not going to be a super, super long thing to get through, because it's 51 pages total. So it's going to be like maybe 5.5, 6 hours of content in that case. I don't know. We'll have to see. So, let's do it again. Non-ischemic chest pain, cardiac. Non-ischemic chest pain, cardiac. Chest pain with atypical characteristics. So we have, let's say for example, physical, EKG, troponins rule out ACS. Well, concern for ACS, see page 3. What about history and physical exam? Okay, for a history and physical exam, let's say heart murmur, syncope, and palpitations. Well, in that case, you do a transthoracic echocardiogram, best initial, TEE, most accurate. So wait. So TT, let's do this. Let's look this up right now. TTE, medical, is transthoracic echocardiogram. Sure, but what about TEE then? Transesophageal echocardiogram. Okay. So TTE, the transthoracic is the best initial, but the transesophageal is the most accurate. So let's say, for example, in that case, we're either going to have aortic valve pathology or mitral valve pathology. See pages 42 to 43, valvulopathies. Again, aortic valve pathology or mitral valve pathology. What about, let's say, for example, we're looking at it, history and physical exam, we're thinking, okay, heart murmur plus or minus fever. What do we do? Modified Duke's criteria and Jones criteria. What about Duke's criteria? Duke criteria, modified Duke criteria, major criteria, positive blood cultures, typical organisms, Staphylococcus aureus, strep viridans, I-check, AHACEK, strep galolyticus, or persistently positive cultures greater than 12 hours apart, or single positive for Coxiella. 2, evidence of endocardial involvement, echocardiogram positive, vegetation, abscess, new partial dehiscence or of prostatic valve, or new valvular regurgitation. Minor criteria for Duke criteria: predisposition, IV drug use, prostatic valve, valve lesion with significant turbulent flow. 2, fever. 3, vascular phenomena, arterial emboli, septic pulmonary infarcts, mycotic aneurysm, Janeway lesions, conjunctival hemorrhages. 4, immunological phenomena, glomerulonephritis, Osler nodes, Ross spots, rheumatoid factor positive, rheumatoid positive, okay. 5, microbiological evidence, positive blood cultures not meeting the major criteria. What about Jones criteria? Jones criteria, major manifestations, carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestations, poly/monoarthralgia, fever, elevated inflammatory markers, ESR, CRP. Prolonged PR interval unless carditis is major criterion. Okay. So let's say we do that. And let's say, for example, the Jones criteria, 2 major or 1 major plus 2 minor manifestations and preceding group A strep infection. What do we think? Acute rheumatic fever. See pages 42 to 43, valvulopathies. What about, we said, modified Duke's criteria, definite 2 major or 1 major plus 3 minor, or 5 minor, or possible 1 major plus 1 minor, or 3 minor. Well, that sounds like a lot of different options, I guess, you could choose from. But anyways, in that case, you think infective endocarditis. So see pages 42 to 43, valvulopathies, and page 23, endocarditis, for that one. What about you do a history and physical exam? We're saying, oh, weight gain, orthopnea, right? Orthopnea, edema, and elevated jugular venous pressure. In that case, we think about acute decompensated heart failure, okay? See pages 12 to 14, heart failure. What about, okay, sure, we have chest pain with atypical characteristics. We have history and physical exam. We're seeing radiation to back, unequal blood pressure between the arms. What do we think? Go for a chest x-ray, and we might see a widening of the mediastinum. In that case, do a CT angiogram of the chest, MRI, or a transesophageal echocardiogram. What do we see? Dissection flap present, in which case it's aortic dissection. See pages 497, vascular diseases. We're definitely not covering that one tonight. What about this? Pain is worse with lying flat, better when sitting up. Young, that sounds like, okay. Better when sitting up, age less than 40, recent viral illness. Okay, let's hear about it. EKG. Do EKG, you see diffuse ST segment elevations, PR depression. What do we think? Myopericarditis. So you have transthoracic echocardiogram or cardiac MRI, plus identify potential reversible causes, most commonly idiopathic or viral. See pages 38 through 41, pericardial disease, and pages 12 to 14, heart failure. So that was interesting. So that was all right there, I guess. I don't know. It says non-ischemic chest pain, cardiac. And now we're going right directly into non-ischemic chest pain, pulmonary. And this probably has an explanation to it. No, it doesn't. It doesn't have it. Okay. So this is pulmonary. And this is non-ischemic chest pain, GI. In this case, if that's cardiac, and this goes into non-ischemic chest pain, this is non-ischemic chest pain, cardiac. Well, I could do this probably and not be a big deal. I don't know. Let's go for this one. Non-ischemic chest pain, pulmonary. We're on page 9 right now. Chest pain with atypical and non-cardiac characteristics. History and physical exam. Let's say we see cough, sputum, hemoptysis, fever. Do a chest x-ray. What do we think? Pneumonia. If we think it's pneumonia, go for antibiotic management, which is not specific, but see pages 165 or 167 for pneumonia. What about acute chest pain, shortness of breath, hypoxia, a new DVT, sinus tachycardia? What do we think? CT angiogram of chest, or a VQ scan. In that case, we're thinking PE, pulmonary embolism. So do a BNP, troponin plus or minus transthoracic echocardiogram, and then you would do a systemic anticoagulation. See pages 267, 275, 285, pulmonary embolism, pages 113, anticoag table. Okay. Next one, you think, let's say it's sharp pleuritic pain. In that case, auscultation or chest percussion. If you have absent breath sounds, trachea deviation, tympanic, what do we think? Tension pneumothorax, okay? In that case, needle decompression and chest tube placement. See pages 368, pneumothorax. After that, let's say we have something like this. Pleuritic pain, shortness of breath, plus or minus asymmetric dull bass on percussion. What do we think? Pleuritis. Pleuritis, do a chest x-ray. In that case, you might have pleural effusion, in which case other signs or symptoms concerning for cirrhosis, cardiac heart failure, or nephrotic syndrome. In that case, you could either treat the underlying cause with diuretics. I guess the other option, it says here, thoracentesis and pleural fluid studies, cytology, LDH, pH, protein, glucose, gram-stain, and cultures. You do an autoimmune workup, identify any causative medications, procainamide, hydralazine, isoniazid, age-appropriate cancer screening, and then plus or minus, if it's positive for that, you do treat the underlying cause, okay. If it's negative for that, it's idiopathic or post-viral origin, in which case give supportive treatment. What about we have elevated sputum production, that makes more sense, shortness of breath, and wheezing. It's either asthma or COPD. Treated with inhalers, LAMA, LABA, SABA as needed, steroids. So those are LAMA, long-acting muscarinic antagonist. LABA, long-acting beta antagonist. SABA, short-acting beta antagonist. As needed for steroids. And this is page 258, COPD, pages 258 to 259, 272, 275, 278, asthma. But what about cough, hemoptysis, B symptoms, which means, let's talk about this for a moment. B symptoms, fever, drenching night sweats, and loss of greater than 10% of body weight over 6 months. Okay. So we have cough, coughing up blood, B symptoms, no risk factors for TB, smoking history. What do we think? Do a CT chest due to a CT scan of the chest. If that's positive, we're looking for malignancy, primary versus metastatic disease. So you see pages 258, pages 280, 284, and 290. Think about lung cancer. This is lung cancer. This is what we're considering, you know? Okay. Now, we're on page 10. And the video is, we can probably pull one more off as long as it's not, yeah, we could probably pull this one off. That's probably fine. Let's say it's not, we're talking about non-ischemic chest pain, GI. So chest pain of atypical and non-cardiac characteristics. History and physical exam. Let's say, for example, we're doing a physical exam and history, and we say, oh, epigastric discomfort, bad taste, cough, hoarseness. What do we think? GERD, gastroesophageal reflux disease. You treat that with PPIs, proton pump inhibitors, right? Aluminum hydroxide, I think that is, / magnesium hydroxide. Wait, aluminum HO. What does that mean? Aluminum HO. No. / magnesium OH. Is that right? It says here, so aluminum hydroxide and magnesium hydroxide, often abbreviated as AlOH3, magnesium OH2, a combination of antacids quickly relieve heartburn. So I think they might have just spelled that incorrectly, I guess. I don't know. So PPIs, aluminum hydroxide / magnesium hydroxide, viscous lidocaine, risk factors for malignancy or peptic ulcer disease, in which case you do an EGD, which I don't know what that is. I'm learning so many new acronyms, right? It's a esophago-gastroduodenoscopy. So do an esophago-gastroduodenoscopy, plus or minus biopsies. Think about duodenal ulcer or gastric cancer. See pages 406, peptic ulcer disease. What about we have this sort of atypical, non-cardiac characteristic chest pain. This is persistent vomiting preceding chest pain. Think about Mallory-Weiss tear. So you have acute, let's say we have acute, after a physical examination, we have acute severe retrosternal chest pain. If we have that retrosternal chest pain, think about doing a CT scan or an esophagram. Think about esophageal perforation. Then go for that. We can talk about testing, which gives free perforation or contained perforation. If it's free perforation, do surgery. If it's contained perforation, go for NPO, do not eat food, right? NPO. Antibiotics, nasogastric suction. If it's contained. If it's not, go for surgery. Chest trauma is a similar way. Let's say we have chest trauma, go do CT scan of esophagram. Again, esophageal perforation. Again, if it's contained, NPO, antibiotics, nasogastric suction. If it's free, perforation, surgery. Okay, what about squeezing retrosternal pain squeezing retrosternal pain or spasm plus or minus dysphagia? What do we think? Esophageal spasm. Okay. Well, in that case, you go calcium channel blockers, tricyclic antidepressants, and nitrates. See pages 54 through 56, dysphagia. What about this? Persistent severe epigastric pain, history of heavy alcohol use. What do we go for? Amylase, lipase, plus or minus CT scan. If that's positive, pancreatitis, right? In that case, don't NPO, don't give him food. IV fluids, nothing. Sorry, NPO. Let me just specify what that exactly means in the Latin. NPO means nothing by mouth, but in Latin it says nil per os, so nothing by mouth. Not just food, but anything else. So NPO, IV fluids, pain management. See pages 421, pancreatitis. And then finally, postprandial fullness, early satiety, bloating, epigastric pain, or burning. EGD, against the esophagogastroduodenoscopy, plus or minus biopsies and H. pylori testing. Positive H. pylori associated dyspepsia. Treat H. pylori infection. See H. pylori infection, see 119, 121 lymphoma. That's really not specific, is it? To my knowledge, H. pylori testing is like you're going to do things like a PPI. You can treat with a macrolide, like specifically, I think, clarithromycin. And then you got to treat with like some sort of antibiotic. I'm not quite sure which one. I think. Don't quote me on that one. In fact, let me go look it up right now. Typical H. pylori treatment. They say a PPI, like a omeprazole. You treat them with an antibiotic, multiple antibiotics for 14 days. But I'm seeing you could do where's a triple therapy? There's a quadruple therapy. They say bismuth, subsalicylate, subcitrate, tetracycline, metronidazole. Yeah, what I think I've heard is clarithromycin, a proton pump inhibitor like omeprazole, and like some other drug at the same time. Again, don't quote me on that kind of stuff. Look into this yourself, or look into the book on this particular question. I just wanted to get a little bit better information on that front. So let's say we did an esophagogastroduodenoscopy plus or minus biopsies and H. pylori testing. Let's say it was negative. In that case, do a trial proton pump inhibitors, H2 blockers, plus or minus empiric H. pylori treatment. In that case, if we have persistent pain or other etiologies are ruled out, well, then you have functional GI pain. In which case, do antidepressants, prokinetic agents, plus or minus psychotherapy. Because at that point, we don't even have a reason for why it's happening. You just have pain, and we don't know what it could be. In which case, they're saying, just give them psychotherapy. Give them antidepressants, prokinetic agents, Anyway, so we're on page 11 right now for non-ischemic chest pain, musculoskeletal. You know what? Next one's on congestive heart failure, so I just might wrap this up just because it'd be more reasonable. It's more in tune with everything else that's going on around it, just for the sake of completion. So non-ischemic chest pain, musculoskeletal, chest pain of atypical and non-cardiac characteristics, history and physical exam. So let's say we do a history and physical exam, and we see chest wall tenderness, recent strenuous activity. In that case, you see swelling of costal cartilage. If we're looking at it further. In that case, we think positive or minus. If it's positive for swelling of costal cartilage, we're thinking Tietze syndrome. I don't know how to pronounce that. And if it's negative, let's say it's not. We have the chest wall tenderness, but we don't have the swelling of the costal cartilage. In that case, it's negative. We have costochondritis. But in both cases, be it Tietze syndrome or costochondritis, we have treatment with anti-inflammatory medications, NSAIDs, acetaminophen, topical lidocaine, or NSAIDs. Okay, what about this? History of rheumatic disease, diffuse pain, widespread soft tissue. In that case, we're thinking rheumatic chest pain. What do? Treat underlying rheumatological pathology, anti-inflammatories. What about shooting pain from the neck, upper extremity, and paresthesia? What do we think? Cervical MRI. You do a cervical MRI, you see cervical or thoracic disc disease. These are red flags. What are the red flags? Red flags, progressive motor deficits, suspected neoplasm, myelopathy, epidural abscesses, bilateral symptoms. Let's go back to it. So those are red flags. If we have red flags, they're positive for red flags, we just mentioned. Urgent MRI. You do that, you do neurosurgical evaluation. What if they're negative for that? We have cervical or thoracic disc disease, but it's negative for those red flags. What do? Conservative management, NSAIDs, collar, short course of steroids, physical therapy. Okay. What about pain? We have pain, dysesthesia, or dysesthesia, numbness, and weakness. What do we think? Addison's disease. Confirm with the CT scan, venous and arterial duplex. If you have abnormal cervical ribs, muscular anomalies, compression of the neurovascular bundle, well, then you probably have thoracic outlet syndrome, right? In which case you do physical therapy. If you have vascular compromise and or acute/subacute progressive neurological weakness, then you actually have to do surgical decompression, because at that point it's more serious, right? Let's say, for example, we have pain worsening with use, worse at insertion of the deltoid muscle. In that case, you probably have subacromial bursitis. How do you treat it? With NSAIDs, steroid injections, and physical therapy. A lot of the similar treatments, right? You do a lot of these pain management and like physical therapy. What about this? Mass apparent on exam, history of malignancy, B symptoms. Again, B symptoms, we were talking about that just before. B symptoms are fever, drenching night sweats, and loss of greater than 10% of body weight in the last 6 months. In that case, we're thinking chest wall tumors, right? Tissue biopsy, CT the chest. Treat according to stages of pathology, chemotherapy, surgery, radiation. Okay, now we're on page 12, and it's going to be about congestive heart failure. I will not be doing this section for today. We got about, technically, pages 1 through 11 for today done. In this particular video, I should say. I did an earlier video today. But regardless, hopefully this is of good use to you. I hope this is not going to be too long, but as likewise, or could say conversely, very informative on these matters at hand. Basically, as any other person who's studying whatever it might be, I want to be able to get as much out of it with as little effort as possible. So, hopefully this was a very enjoyable video for you. Smash that like button, hit subscribe, leave a positive comment. I'm counting on them, right? And have a great rest of your evening, morning, night, day, whatever it may be, whenever it may be. Thank you, and goodbye.